Hey guys, welcome back to my channel. My name is Alex and today I wanted to talk about the myths surrounding low AMH, DOR, and POI. If you're new here, I was diagnosed with this condition that has many names about 3.5 years ago. I had low estrogen, I had low AMH, and I had high FSH, which are all markers of this condition. Now, at the time of my diagnosis, I was having some irregular cycles, so I was having some longer ones and some shorter ones, so longer like around 40-ish days, shorter around 15-ish days, somewhere around there. I never lost my period, but I did have like the hormonal markers of this issue. So it is a devastating diagnosis, and I myself have personally experienced a lot of misinformation around this diagnosis and have personally firsthand experienced the damage that misinformation does. A lot of doctors kind of spread this misinformation without knowing it because they're not experts in the condition. This is a rare condition. Not a lot of doctors know a lot about it. One of my gynecologists explained this to me, that they generally only see maybe one person every once in a while that has this condition. It's not common. That's why so many doctors are kind of confused about it. Maybe their knowledge is outdated. It's just very poorly understood in general. I wanted to make this video so that if you have recently been diagnosed with this, you can sort through some of the noise and understand that some of the stuff that's being told to you is not actually accurate. And science is always evolving. I am not a doctor and I am not a scientist, but I am someone with this condition and I have had it for at least 3.5 years. I am neuroatypical, so I have done a lot of research about this obsessively for the entirety of the time that I've been under this diagnosis. I'm not here to give you medical advice, so please make sure you consult a qualified healthcare professional. I just wanted to bring some nuance and clarify some things that are often told to women with low AMH, DOR, or POI. Okay, first, before we start with this, we need to talk some definitions. So a lot of times terms are used interchangeably, and that is not okay with this diagnosis. There's this misconception that POI is menopause, is early menopause. That is not true. It's not true. Menopause and POI are different. Menopause is the complete cessation of ovarian function. POI often includes unpredictable and intermittent ovarian function. POI is also diagnosed under the age of 40. So again, POI, primary ovarian insufficiency, is not the same thing as menopause or early menopause. That is the first misinformation that we have to combat here. Again, with POI, ovarian function can be intermittent. Cycles may come and go. Ovulation can still occur, and spontaneous pregnancy still can happen. Major medical organizations explicitly state that POI should not be defined as early menopause. That distinction really matters. Let's go ahead and get into the misconceptions/myths. So I've seen this one a lot. I read an article probably about 2 years ago that severely traumatized me. And then I had someone on TikTok recently comment something about this on one of my videos, and I had to stop it right there because this is a misconception that causes damage and unnecessary fear in women with low AMH, DOR, and POI. This misconception is that if you get pregnant, you will automatically be in menopause after you give birth if you have POI or DOR. This is one of the most common and most fear-inducing myths. Here's the plain and simple fact. Pregnancy does not cause menopause. During pregnancy, ovulation is suppressed and the placenta is producing most of your hormones. But that is temporary suppression, not permanent ovarian failure. If someone's ovarian function declines after pregnancy, that is almost always due to the underlying ovarian condition, age, and time passing, not because pregnancy used up the ovaries. And in fact, large population studies show pregnancy and breastfeeding are actually associated with a lower risk of early menopause. Correlation does not equal causation. Misconception number 2, and this one is so common too. I have so many women coming to me in my DMs on TikTok and Instagram about how they're terrified that they're gonna go into menopause right away. And this just breaks my heart because that was my fear too, because I had a fertility doctor tell me that my ovaries would shut down within 6 months to a year. This was a famous fertility doctor that gives lectures in other places, and he told me my ovaries would shut down within 6 months to a year, which is absolutely asinine. AMH cannot reliably predict your age of menopause. AMH only reflects the amount of small follicles developing in the ovaries at the moment the test is performed. It does not measure your entire ovarian reserve. It's only the small follicles that are currently developing. It's a snapshot, it's not a crystal ball. And if you have recently come off of birth control, or you have low vitamin D, or something like this, if you've recently had a cycle interruption, AMH can sometimes be artificially lower. So we're anchored in reality here, AMH does decline with age, and AMH is undetectable in menopause. But that does not mean that if you have low AMH, you are definitely going into menopause earlier. Now, I'm going to link all the studies in the caption for you guys so that you can see where this data is coming from. I'm not just spouting off crap, I'm going to back up what I'm saying in the caption. So if you are interested to see those studies, make sure you check that out below. Here is the key distinction. On a large population level, AMH number may correlate with menopause timing, but on an individual level, it is not possible to predict someone's age of menopause. That is because some women just recruit less follicles per cycle, and some women just have a lower ovarian reserve. It doesn't necessarily mean they're going to go into menopause earlier. Is it more common with women with low AMH to go into menopause earlier? Yes, it can be. But also, women with higher AMH can still go into menopause early. Just AMH is not the only deciding factor of the age that you will go into menopause. So major reviews have concluded that AMH is not suitable for clinical prediction of age of menopause. So when someone says low AMH means you will definitely hit menopause early, that is just not supported by the data. So misconception or myth number 3, low AMH means you're already in menopause. That's also not true. AMH reflects how many follicles are being recruited into growth, not necessarily your entire ovarian reserve. How fast follicles are lost overall, how efficiently the ovary uses its reserve, and how ovarian aging will progress over decades. Research shows there is enormous variation in AMH levels in women of the same age. Women with similar AMH levels can reach menopause very many years apart. Some women with low AMH still reach menopause at the average age, which is around 51 years old. AMH is associated with risk trends, not destiny. So now let's move on to misconception / myth number 4, which is every woman recruits follicles in the same way. That's not true. Some women recruit fewer follicles per cycle, and that just may simply be how their ovaries function. Follicle recruitment is influenced by genetics, FSH sensitivity, intra-ovarian signaling, and metabolic and inflammatory environment. The ovary is a complex ecosystem. It is much more than just a vault of eggs. The same nerves that run throughout our nervous system also run throughout our ovaries. If we are stressed, our ovaries are stressed. They know when we're in fight or flight. It's a much more complex ecosystem than just an egg vault. So a woman can have fewer follicles entering growth each month and lower AMH as a result, yet still ovulate consistently and maintain cycles for many years. In other words, low AMH does not always mean rapid depletion. Sometimes it reflects a slower or more conservative recruitment pattern, not always accelerated ovarian aging. This is one reason that AMH alone cannot predict menopause timing. And moving on to misconception / myth number 5, the ovarian reserve is totally finite and non-regenerative. This is where things get really interesting, and we're talking about science that has not yet been accepted into the mainstream dogma. There are more papers that have found ovarian stem cells, or OSCs, within the ovaries of women than there are papers that were not able to find them, which suggest potential ovarian regeneration potential. This does not mean that they can create a completely new reserve or that we renew our egg reserve like men renew their sperm, but there is some suggested regenerative potential. And for decades, we've been taught that women are born with a fixed number of eggs that is non-renewable, and the amount of eggs that we have was set in stone, and we would just lose eggs every single cycle. But the existence of ovarian stem cells contradicts that theory. Again, more than 40 peer-reviewed studies have been able to find them, and I believe it's something like less than 10 have not been able to find them. So the existence of these cells suggests that the ovary may have limited regenerative or reparative potential. I'm sorry if you hear my dog playing with her squeaky toy in the background. So it's important to realize that this does not mean infinite regenerative potential, and it does not guarantee fertility restoration, but it does challenge the idea that the ovary is nothing more than an egg vault constantly losing eggs. Many researchers now view ovarian function as dynamic, responsive to environment, influenced by inflammation, immune signaling, and metabolic health. And this explains why ovarian function can fluctuate. Some women regain their cycles, some respond to interventions, and some see changes over time. The ovary is not a light switch, it's a living tissue. The last misconception that I want to talk about is this idea that POI is like a single health condition. It is not. It is an umbrella term for different causes that lead to the same result, if that makes sense. So not everyone's POI is caused by the same thing. It can be genetics, it can be inflammation, it can be autoimmunity, it can be from getting some kind of surgery done on your ovaries. It can be caused by endometriosis. There are a lot of causes for POI. It can also be environmental. That's what I have previously thought has been one of the contributing factors to my own, because my symptoms started to show up around the time when I got bedbug fumigation done in my apartment in New York, and I was exposed to the poison and lived with the poison on the floors in my apartment for probably around a year. So, but again, even with genetic causes, there are different genetic causes that can cause POI. So everybody's potential for improvement is different. In closing, I hope that this helped you to clear up some misconceptions that you may have been told by medical professionals. It's not because they're not good at what they do. It's because this is a rare condition that they spend a very minimal amount of time with their training on. And there's a lot of outdated information that many doctors keep telling us. That's the reason for the continuation of the spread of misconceptions and misinformation about this condition. I hope that this helped clear up some of the fear that you may be feeling. Just know that POI does not necessarily mean permanent ovarian failure, and I always like to believe that there can be a cause for hope. Just so you guys know, one person's outcome is not everybody's future. So if you have seen stories of someone's ovarian function permanently turning off, that's not necessarily your story. If you're in this space, you are not broken and you deserve accurate information. Thank you guys so much for watching. Please consider subscribing if you haven't subscribed yet. I do lots of structured videos like this, and I also share my healing and fertility journey in vlogs. Thank you guys so much for watching. I hope to see you in the next one. Bye guys.